You take one of these medications every morning. Your doctor renews the prescription. Your blood pressure is controlled. But there's something about these three drugs that almost nobody discusses at the appointment. Your doctor didn't explain the difference between them. Not really. Not in the way that matters for what happens inside your brain over the next 10 years. And most people refill the same prescription year after year without knowing that difference exists. A meta-analysis published in the AHA journal Hypertension, 14 studies, nearly 13,000 adults, found that people taking ACE inhibitors like Lisinopril or ARBs like Losartan had measurably better memory recall over time compared to those on other blood pressure medications. The mechanism: these drugs cross the blood-brain barrier. Amlodipine does not. In this video, I'm going to show you what that difference means in practice, what the 2025 guidelines changed about your target, and the 3 questions worth bringing to your next appointment. This prescription right here: Amlodipine, Losartan, Lisinopril, 3 of the most commonly prescribed medications in the country for adults over 60. Most people on one of these have been on it for years. The prescription gets renewed, the blood pressure is controlled, and the conversation ends there. But there's something about these 3 drugs that almost nobody covers at the appointment, and it has nothing to do with your kidneys, nothing to do with your potassium levels. It has to do with your brain. I'm James Reyes. I'm not a physician, and honestly, that's exactly why I can tell you what your doctor might not have had time to explain. I'm a researcher, and I've been going through the medical literature on blood pressure medication and brain health for the past several months, partly because of what I watched happen to my father over more than a decade of cardiovascular disease, and partly because of what the 2025 guidelines changed that most people on long-term medications still haven't heard about. Nothing in this video is medical advice. What it is the research your next appointment may not cover. Drop a comment right now with just your age, nothing else.
I want to see who's watching, because what I'm about to show you depends on exactly where you are in this. Here's what most people believe. If the blood pressure is controlled, the medication is doing its job. That's the frame your doctor works from. One number, the blood pressure reading, as the primary measure of success. And for decades, that frame made sense. We had limited tools. We had limited time per appointment. We had limited understanding of what these drugs were doing beyond the vascular system. What we now know, and what the research published in the last 4 years has made increasingly clear, is that this frame is incomplete. These 3 medications don't just act on your blood vessels. They interact differently with your central nervous system. They cross or don't cross the blood-brain barrier at different rates, and that difference, depending on which drug you're on, is associated with measurably different outcomes in cognitive function over time. That finding has been in the literature since at least 2018. It was reinforced in 2021, and as of today, most people renewing their prescription every month have never heard it mentioned at an appointment. My father was on blood pressure medication for years. Different doctors across different specialties, cardiologist, internist, general practitioner, each managing their piece of the picture. The question of what those drugs were doing to his brain as a system was never asked, not once. And I don't say that to blame anyone. The appointments were 15 minutes, the blood pressure was controlled, the system called that a success. In my view, the most under-discussed question in senior cardiovascular care right now is not whether to treat blood pressure, it's which class of medication you're on and what it's doing beyond the vascular system. The evidence is there, the conversation isn't. And that gap between what the research now shows and what's happening in your doctor's office is costing people their cognitive future. When your doctor last renewed your blood pressure prescription, did they explain the difference between your medication class and any of the alternatives? Did the word brain come up? The research I'm about to show you is not theoretical.
It tracked nearly 13,000 people. It followed them over years,
And the finding it produced is the kind of thing that should have changed how these conversations happen, but hasn't yet changed them nearly enough. And there's a study published in the AHA journal Hypertension, a meta-analysis of 14 separate research cohorts tracking nearly 13,000 adults that shows exactly how deep this goes. That's where we're going next. In 2021, a team of researchers published a meta-analysis in Hypertension, one of the American Heart Association's flagship journals. 14 studies, 12,900 adults over 50. The question they were trying to answer was whether the class of blood pressure medication, not just the effectiveness at lowering pressure, had any detectable association with cognitive outcomes over time. The answer was yes, and the direction of the effect was specific. Adults taking ACE inhibitors, drugs like Lisinopril, or ARBs, drugs like Losartan, that cross the blood-brain barrier showed measurably better memory recall over the follow-up period compared to adults on other blood pressure medications. Not dramatically better, not the kind of difference that appears in a single appointment, the kind of difference that compounds over years and that you'd only see if you were tracking the same people with the same cognitive tests across a long enough window of time. I want to be precise about what this finding means and what it doesn't. This is observational data. It shows an association. It does not prove that lisinopril or losartan prevent dementia. It does not prove that amlodipine causes cognitive decline. What it shows is a statistically significant difference in cognitive trajectory between people on different classes of blood pressure medication over a period of years that the current prescription model has no mechanism for discussing. The mechanism researchers point to involves the Renin-Angiotensin system, a hormonal pathway that regulates blood pressure but also plays a role in brain inflammation, neuronal health, and beta-amyloid clearance. ACE inhibitors and some ARBs act on this system not just in the vasculature, but in the brain itself. Amlodipine, a calcium channel blocker, acts primarily on smooth muscle in blood vessels. It doesn't have the same central nervous system profile. 3 weeks ago, I was going back through this literature, specifically looking at how these findings had or hadn't translated into clinical guidance, and what I found was that the 2025 AHA-ACC Guideline, the most comprehensive update to blood pressure management in nearly a decade, addresses targets, thresholds, and individualization extensively. What it doesn't do is give clinicians a protocol for discussing medication class selection in the context of brain health. That conversation is still largely left to the individual physician, if they know the research, if they have time, and if the patient asks. Most patients don't ask because they don't know there's a question to ask. Think about what that means in practice. A woman in her late 60s is prescribed amlodipine for blood pressure. It works. Her pressure is controlled. She renews the prescription every year. Over the next decade, she takes that medication faithfully, and she never knows that a different class of medication, equally effective at lowering her blood pressure, may have had a different profile for her brain. Nobody told her there was a difference. Nobody gave her the language to ask. That's not a failure of any individual doctor. It's a structural gap in how the conversation is designed. Write this down. The question is not whether to treat your blood pressure. The question is which class of medication you're on and whether that class is the right fit for your full picture, including what you want your brain to look like in 10 years. If nearly 13,000 adults were tracked specifically for this difference, and the difference was real, why hasn't it come up at your last appointment? Before I get to the part that changes everything, the part that most videos on this topic get completely wrong, I need you to hold what you just heard. Now here's where it gets counterintuitive, because the study I just showed you raises a question that almost nobody in this space is asking.
If ACE inhibitors and ARBs are associated with better cognitive outcomes, and the mechanism is plausible,
Why is amlodipine still so commonly prescribed? And what should you do with this information if you're currently on amlodipine and it's controlling your blood pressure effectively? The answer is more nuanced than most YouTube videos on this topic will tell you. And the nuance matters because getting this wrong in either direction has consequences. Write this down. The 2025 AHA-ACC Hypertension Guideline, the first major update in 8 years, made a specific change that affects anyone currently on a long-term blood pressure prescription. The previous guideline set a treatment threshold of 130/80 millimeters of mercury. The 2025 guideline maintains that threshold, but it now explicitly encourages a target of below 120 for many adults based on data from 3 major trials: STEP, Esprit, and BPROD. That's a significant shift, and it means that if your blood pressure has been controlled at 135 for the last 3 years, your doctor may be working from a target that is now considered suboptimal. But, and this is the part that doesn't fit in a headline, the same guideline explicitly recommends individualized targets for older or frail adults. The data from Sprint, which informed much of this shift, was conducted in adults who were not frail, not institutionalized, and not managing multiple comorbidities simultaneously. For someone in their late 70s managing 3 chronic conditions, a target of below 120 may not be appropriate. The guideline says that. Most summaries of the guideline don't. And look, this is one of those moments where I want to say something carefully. This is not a situation where the guidelines are wrong and your doctor is wrong. This is a situation where the guidelines are more specific than most 15-minute appointments allow a doctor to communicate. The difference between your blood pressure target is 130 and your blood pressure target should probably be below 120, but that depends on your age, your frailty status, your comorbidities, and your medication class. That difference requires a conversation that most appointments aren't structured to have.
Now, let's bring these 2 threads together, the cognitive data and the guideline update, because they're not separate conversations, they're the same conversation. If you're on amlodipine, your blood pressure target may now be below 120 instead of 130. But amlodipine doesn't have the cognitive profile that the hypertension meta-analysis associated with better memory outcomes. If you're on Lisinopril or Losartan, the cognitive data looks more favorable, but both of those medications require specific monitoring that frequently doesn't happen. Lisinopril acts on a system that the aging kidney processes more slowly. Function declines approximately 1% per year after 40, meaning the drug stays in your system longer as you age. Losartan can elevate potassium, and if you're on a diuretic or taking a potassium supplement, that combination can push potassium to a level that creates cardiac risk. The monitoring that should happen when you start or continue these medications, serum creatinine, eGFR, potassium levels, checked within 2 to 4 weeks of initiation and regularly thereafter, frequently doesn't happen on the timeline recommended. Not because your doctor doesn't know, because the system isn't designed to prompt it automatically. If your medication class affects your brain differently and your blood pressure target may have changed without anyone telling you, how would you know? What would you have to ask? You now know something most people walking out of their doctor's office this week don't know. The question is what you do with it. Here's what I do. 3 things: specific, actionable, clinically reasonable. Meaning these are questions your doctor can actually answer at a standard appointment. Number 1, ask about your blood pressure target. The specific language that works is, with the 2025 AHA-ACC guideline update, is my current blood pressure target still the right one for my age and my situation? Should we be aiming below 120, or is there a reason my target is different? This question does 3 things. It signals that you've done your homework. It opens a conversation your doctor may not have initiated because they assumed the current target was already communicated. And it gives your doctor the chance to explain whether a more aggressive target applies to you or whether your individual picture calls for something different. Both outcomes were useful. Number 2, ask about monitoring. The specific language. When did we last check my kidney function and potassium levels since I've been on this medication? Is that something we should be doing on a regular schedule? This is especially important if you're on Lisinopril or Losartan. The standard recommendation is to check creatinine, eGFR, and potassium within 2 to 4 weeks of starting the medication, and then at regular intervals based on your baseline kidney function. If you've been on the medication for years without a dedicated review of these numbers, you may have an incomplete picture of how your body is processing it right now. Number 3, ask about medication class. This is the conversation the research supports and the one most appointments don't reach. The specific language. I read something about ACE inhibitors and ARBs crossing the blood-brain barrier and having a different cognitive profile than calcium channel blockers. Is that something worth considering given my age and what I want for my long-term brain health? You don't need to cite the journal. You don't need to know the mechanism in detail. You need to open the door and let your doctor walk through it with you. In some cases, your doctor will tell you that your current medication is the right choice for reasons unrelated to the cognitive data, and that's a legitimate answer. In other cases, this question may prompt a conversation that hadn't happened yet. A recommendation is not a verdict, and a prescription that was right 3 years ago deserves to be questioned in the context of what we know today. Nothing I've shown you today is a reason to stop your medication. I want to say that clearly because the data on untreated hypertension is not ambiguous. Uncontrolled blood pressure is associated with stroke, heart attack, kidney failure, and cognitive decline. The goal of this video is not to create doubt about treatment. The goal is to give you the language to have a more complete conversation about which class, which target, which monitoring, because that's where the gaps are.
I'm not your doctor, and you should not make changes to your medication based on anything I've said here. What I am is a researcher who reads this literature because of what I watched happen to my father and what I learned the hard way about my own body, and who believes genuinely that the gap between what the research shows and what the average appointment covers is one of the most consequential gaps in senior healthcare today. You are not a passive recipient of medical decisions. You are an informed participant in your own health. Let's recap the 3 things you're taking out of this video. 1. The 2025 AHA-ACC guideline may have changed your blood pressure target, and your current prescription may have been calibrated to an older threshold. Ask. 2. If you're on Lisinopril or Losartan, your kidney function and potassium levels should be monitored on a regular schedule. Ask when it was last checked. 3. There is a measurable difference in cognitive profile between ACE inhibitors and ARBs that cross the blood-brain barrier and calcium channel blockers like Amlodipine. It is worth one conversation with your doctor. Which of these 3 questions are you bringing to your next appointment, and which one surprised you most? If you're walking away from this video differently than you walked in, drop "informed" in the comments. I read every single one. If this is the kind of research you want to keep seeing, the subscribe button is right there. I don't post every day. When I post, it matters. There's one more layer to this that I didn't cover today, and it changes how you interpret everything I just showed you. It's about what happens when low bone density and high coronary calcium appear in the same patient, and how blood pressure management intersects with cardiovascular calcification risk. That's next. Nothing in this video is medical advice. Everything I've shown you is based on peer-reviewed research, and it should go directly into your next conversation with your physician, not instead of that conversation, alongside it.